Welcome to this podcast on dots and globules. Although dots and globules can be seen in different types of skin lesions, it is important to highlight that the presence of atypical dots and globules is suggestive of melanoma. In fact, atypical dots and globules are one of 10 melanoma-specific structures. Dots are defined as small round structures with a diameter less than 0.1 millimeter. Black dots represent melanin in the stratum corneum or upper parts of the epidermis. Here's a nevus revealing black dots within the center of the lesion. These black dots usually represent clumps of melanin in the stratum corneum. Thus, these black dots can easily be tape stripped off as highlighted here. On the left is a nevus with black dots. On the right is an image of the same nevus after tape stripping. Notice that most of the black dots have been removed via the tape stripping. Brown dots represent melanin in the epidermis below the stratum corneum. This lesion has numerous brown dots. These brown dots correspond to nests of melanocytes in the spinous layer or at the dermo-epidermal junction. Here's an example of a cluster of melanocytes below the stratum corneum. This cluster would correspond to a brown dot. Brown dots on the network lines, as shown in the close-up image here, correspond to melanocytic nests at the tips of reedy ridges. Blue-gray dots, also known as granules, correspond to free melanin or melanin in melanophages in the papillary dermis. Here's an example of a lesion with multiple blue-gray dots or granules. Histopathology reveals melanin in melanophages and free melanin in the dermis. Red dots correspond with blood vessels seen end-on. Here's an example of a melanoma with multiple red dots in the center of the lesion. Once you have identified the dots, you need to decide whether these dots are typical or atypical. In other words, are they regular or irregular? The presence of atypical dots would be suggestive of melanoma. Brown or black dots located within the center of an otherwise benign-appearing nevus are considered typical. In addition, dots overlying network lines are also considered typical. Dots not located in the center of the lesion or not overlying network lines are considered atypical, as exemplified by the melanoma shown on the right. Once again, regular dots are found in the center of an otherwise benign-appearing nevus, such as this reticular nevus on the left. In addition, dots overlying the network lines, as seen in the nevus on the right, are considered typical. Dots on the network correspond to melanocytic nests at the tips of reedy ridges, which is a feature commonly seen in benign nevi. The fact that dots on the network is associated with benign nevi is further corroborated by this study in the Archives of Dermatology, which showed that dots associated with a network did not confer an increased risk for melanoma. Irregular dots are those found towards the periphery of the tumor and not associated with network lines, as is the case in this melanoma. Blue-gray dots, or granularity, can also be classified as regular or irregular. Blue-gray dots that encompass less than 10% of the lesion's surface area in an otherwise benign-appearing nevus are considered regular. If they encompass over 50% of the surface area, they are suggestive of melanoma, as can be seen in the image on the right. For lesions with blue-gray dots encompassing between 10 and 50% of the lesion surface area, other criteria need to be used to decide if the lesion requires a biopsy or not. Red dots correspond with blood vessels, although they can be seen in a variety of skin lesions. When seen in a melanocytic tumor, one needs to consider the diagnosis of melanoma. The most common melanocytic tumors to manifest dotted vessels are listed here. Here's an image of a melanoma with dotted vessels. This lesion also has a few serpentine vessels and crystalline structures, which are commonly seen in melanoma. Dots can on occasion also be seen in non-melanocytic tumors, the most common being pigmented basal cell carcinoma, where one can on occasion find fine brown dots at the periphery. Here's another example of a pigmented basal cell carcinoma with fine brown dots. Now moving on to globules. These structures are larger than 0.1 millimeter and can also come in a variety of colors. The globules, as highlighted here, correspond with melanocytic nests in the dermis. According to the two-step dermoscopy algorithm, the presence of 3 or more, usually brown, aggregated globules defines a lesion as a melanocytic tumor. The color of globules vary. Brown globules usually correspond with nests of melanocytes at the dermo-epidermal junction or papillary dermis. Blue globules correspond with nests below the papillary dermis. Black globules correspond to heavily melanized nests in the upper layers of the skin. In other words, the color of globules from black to brown to blue is a function of the depth of melanin in the skin, also known as the Tyndall effect, and the degree of melanization. Red globules correspond to tumor nests with neoangiogenic vessels surrounding them. This is a feature usually encountered in thicker melanomas. On rare occasions, one can also see white globules in melanocytic lesions, as is the case in this dysplastic nevus. Such white globules can be confused for sebaceous glands or milia cyst. However, when aggregated, such white globules correspond to balloon cell nevus nests. Once globules have been identified, one needs to decide whether they are typical or atypical. Atypical globules would be more commonly seen in melanoma. Typical globules are defined as globules with relatively uniform size and color distributed throughout the lesion, or located in the center, or located around the entire perimeter of an otherwise benign appearing lesion. Any other manifestation of globules would be considered atypical. Once again, regular or typical globules are of similar size, shape, and color and distributed throughout the lesion, within the center of the lesion, or around its entire perimeter. When globules are seen around the perimeter of an otherwise benign appearing nevus, such as a reticular homogeneous pattern nevus, it is indicative of an actively growing nevus. The peripheral globules come in two variants. One pattern consists of tiered globules, one on top of another, like tiers of a cake. Such a pattern is commonly associated with spitzoid lesions. The second pattern is one with globules aligned as a single row around the perimeter or aligned in a staggered or Roman legion pattern, as is often seen in enlarging Clark's nevi. Here's an example of a staggered peripheral globular pattern. This lesion will grow in a symmetric fashion, as was the case in this nevus. Once the lesion enters senescence, the peripheral globules will no longer be visible. Here's an example of a tiered peripheral globular pattern as seen in this atypical spitzoid lesion. Irregular globules are globules with varying size, shape, and color with a random and chaotic distribution. The authors of this study on globules found the same, namely, globules of varying size, shape, and distribution were associated with melanoma. Globules can on occasion also be seen in non-melanocytic lesions such as seborrheic keratosis and basal cell carcinoma. This rough, stuck-on appearing pigmented lesion reveals numerous globular structures on dermoscopy. Such an appearance can be seen in clonal seborrheic keratosis, as was the case in this lesion. In pigmented basal cell carcinoma, one can see non-aggregated blue globules and concentric globules. At times, it is difficult to differentiate between a pigmented basal cell carcinoma and a melanoma. However, the management decision to perform a biopsy will not be affected. With that said, the globules in basal cell carcinoma tend to be blue-gray, non-aggregated, and at times with a concentric morphology. In addition, other basal cell carcinoma features such as arborizing vessels will usually also be present. In a melanocytic tumor, the globules tend to be brown to black and aggregated. In addition, one will often see other features to define the lesion as melanocytic, such as network. Here's an example of a basal cell carcinoma with non-aggregated globules. The arrows point to a concentric globule, which is considered a variant of a spokuli-like area. Although dots and globules can be seen in melanocytic and non-melanocytic lesions, their morphology and the other structures present within a lesion can usually help correctly classify the lesion as a melanocytic or non-melanocytic tumor. When present in a melanocytic lesion, these dots and globules can be present in a typical or atypical appearance. If present as an atypical appearance, one needs to consider the diagnosis of melanoma. Here is a relatively symmetric pigmented lesion, which under dermoscopy reveals numerous atypical dots and globules. These dots and globules correspond to irregular nests of melanocytes in the epidermis and dermis, and in this case was a melanoma. In conclusion, the presence of irregular dots and globules is considered one of the melanoma-specific structures, and the diagnosis of melanoma should always be entertained if one sees these structures. Thank you for your attention.